Annyeonghaseyo. Dear colleagues, dear chairman, thank you very much for the invitation to this very interesting workshop. I'd like to congratulate the team of the Global Fertility Academy. It's been an outstanding meeting so far, and thank you very much for the invitation from Merck Serono. Today we're going to speak about male factor infertility. There will be a succession of 5 different topics. I will try to speak slowly so that everybody understands my mixed French-Australian accent, and we'll see how it goes. So the first presentation will be about the change in pregnancy rates that could be expected with the revision of the 2010 compared to the 1999 WHO references. The second communication is about the correlation between DNA fragmentation index and sperm motility. The third presentation is about the age of sperm donor. The third one would be about the very difficult cases of ICSI for which you have just a few spermatozoa to use. And the last one is about the effect of body mass index and weight in male. So for this first communication, comparison of pregnancy rates at insemination based on total motile sperm counts from the 1999 and 2010 WHO Semen analysis norms. This is a communication from a group in Canada, McGill University, and it's a collaboration with a group of Stanford University. The idea is that WHO constantly revises the manual. For the last 30 years, we have seen a decline in sperm parameters in male. And for the 5th edition in 2010, for the first time, they used only a group of fertile men to establish the reference. They tried to avoid the word of norm, focusing on something that would be a bit more vague, like reference. And if they established that norm with only what's above the 5th centile, it resulted in parameters being much lower than the ones from 1999. So probably you would expect that with this change, the result in the selection of the patient for insemination may be different, and maybe that would yield a lower pregnancy rate. So what they did a retrospective study, and they took all the parameters that they had for 2.5 years. That's more than 2,000 insemination for probably close to 1,000 couples. And they tried to classify those inseminations like normal according to 2010 and 1999. So how did they calculate this? For instance, the total motile sperm count in 1999, according to the WHO manual, would be 20 million per milliliter, multiply 2 milliliter, which is the norm that you would expect, multiply 50%, and you get to 20 million at least. And for the 2010 abnormality, because the norm is lower, 1.5 milliliter, 15 million spermatozoa, only 32% of motility, you get to a result which is lower. And in between, there are those cases that in 1999 would have been normal, but become abnormal according to the new revision. The comparison of the 3 groups obviously shows differences. And the characteristics of the patient in the group were similar. I would like just to point your attention about the number of follicles that were obtained. All of those patients were stimulated. So we're talking about insemination with stimulation, whether it's clomiphene, letrozole, or low dose of FSH. And obviously, because of the selection of the patient according to the number of sperm in the total motile sperm count, the first group has a high number of spermatozoids being used for the insemination. The second group has less, 13 million, and the last group has been selected because they had the lowest number of 3.5. Well, the interesting finding is that, in fact, there is a significant difference for the first group with a higher pregnancy rate of 21%. Those were the best number of spermatozoa being retrieved. But if you compare the norms in 1999 and 2010, there is no difference. In other words, if you have more than, let's say, 10 million spermatozoids in your total motile sperm count, you have a good prognosis with insemination. But whether you have 3, 5, or 6, or 7 doesn't make a big difference. So the conclusion of that study was that abnormal patients by the 2010 guidelines were not less likely to conceive than those who were abnormal with the norms of 1999. And changing those limits had very little clinical impact for the selection of their patients. The second communication is about DNA fragmentation. It's a communication from the group of New York, Cornell. That's a very famous group in the field of male infertility. The group is led by Gianpiero Palermo, who is the person who invented ICSI back in the 1990s in Brussels. So in that communication, they are trying to revisit the DNA integrity in function of sperm motility. What we know is that sperm will progressively deteriorate the quality of their DNA during their long journey in the reproductive tract. We believe that this is something that occurs after the stage of spermatogenesis, rather late during the spermiogenesis. And we know that this fragmentation is related to physiological factors of compaction of the DNA, but also exposure to oxidative stress. And that's probably the reason why there is no clear consensus in the literature if the DNA fragmentation index is really something that is predictive of the success of ICSI. We have conflicting reports. What they wanted to address was the impact of motility as a new parameter. So what they did, they selected a population of couples who previously had gone through IVF ICSI and had failed. And those couples, 253, for a total of more than 500 cycles of ICSI, were assessed with DNA fragmentation index before and after selection of the sperm. And they tried to establish what they call a normalized index. And the idea, I'm going to maybe develop a little bit this index. The idea was to multiply the number of motile sperms in the preparation with the initial fragmentation index that they have in order to ponderate the DFI with the motility of the sperm. And then they have to correct this with a constant. The explanation that the author gave about how the way they calculate the constant was a bit blurry to me, but it's a ratio between the motility before and after the preparation of the sperm. The result is that, first of all, one of the parameters that they had assessed, which I think is quite clear, they had assessed the DFI according to the number of days of abstinence. And very clearly, we have the visualization that the longer the abstinence, the higher the DFI is. And we will see that this is a strong argument to say that the damage to the quality of the DNA occurs in the reproductive tract at a later stage, during spermiogenesis. Second finding of the study, if you compare the analysis of the raw DNA fragmentation index of the whole preparation of sperm before selection, in that example, the average was around 16.5%. But if you measure with micro-selection of each sperms individually and changing the technique from SCSA to tunnel, they visualize that, in fact, for immotile sperms, the DNA fragmentation index was much higher compared to the motile sperm. So interestingly, if you use the DFI, this is not a good predictor of the outcome of the ICSI. If you use, for instance, the cutoff of 25%, if you have cycles for which the DFI was lower than 25, 26% of pregnancy rate, and if it was above 25%, 28%, there is no discrimination. But with the index that they used, trying to incorporate the motility, it shows a significant difference. And in that case, you can see that this modified DNA fragmentation index predicts a little bit better the outcome of the ICSI cycle. Same thing with the implantation rate. That's the graphic on the right. So conclusion, DNA fragmentation positively correlates with the abstinence. It inversely correlates with the motility. And if you normalize the DFI according to the motility, then you may get some kind of estimation of the pregnancy chances and the outcome of the ICSI cycle. A little poll in the audience about the age of the captain. According to this study that was done in the UK and presented at Munich this year in the ESHRE, we're talking about sperm donation. What do you think is the most important factor? The one that contributes to success? Is it the paternal age? Is it the advanced maternal age? Is it both? We know that sometimes younger women may contribute to compensate for an advanced age of the male. We're going to come back to this, to the importance of maternal age. So that communication, age of the sperm donor, does it really matter? An analysis of 1,048,576 assisted reproduction treatment cycles that was presented from a group from the UK, from Newcastle. As being myself an aging father, I had my twins when I was 41. I was very interested by the report of this communication. My twins are very good at IRT. They've been following the ESHRE in London and in Munich. And I have to say that I don't know if the age of the donor really matters, but I think that the age of the father really matters. Especially when it's 4 o'clock in the morning and the baby is crying. I don't think that advanced maternal and paternal age, more than 40, you react in the same way. You don't have the same endurance, for sure. So at 4 o'clock, it certainly matters. So what's the finding of that study? The reason behind that study is quite obvious. There is, all around the world, maybe it's not the case in certain Asian countries. We had a discussion last night. I suppose that, for instance, in Indonesia, it's not legal to perform sperm donation. And there are probably some differences among the countries. But in most Western countries, we have now the obligation to give some traceability and the possibility to divulge the identity of the donor. This is the right that the offspring have. And this has pushed towards a shift of older men giving the sperm, not being so concerned of that one day the child would be able to recognize them. So if you have an older cohort of donor, then you should ask yourself, well, is it really safe? Do we guarantee the same pregnancy rate? Is it the same result? So that was the reason why they did that study. They had more than 1 million cycles of ART available in a public database that was from the HFEA. And out of this 1 million cycles, they could identify 200,000 cycles of donor insemination and IVF. And they selected, because they wanted to avoid some biases, only the first-time cycles. So that's a total close of almost 40,000 cycles. And those cycles, they did a separation according to the age of the women, young women with a good potential, and older women with a decreased potential for fertility. And then they further separated this into 6 categories according to the age of the sperm donor. Very young donors, 20, 25, 30, 35, up to the age of 45. And in fact, the result is compelling. There is no impact of the age of the sperm donor in their study. So we know that IVF in young women works much better than IVF in older women, and that works much better than IUI in younger women, and that works much better than IUI in older women. But there is no visible trend according to the age of the male. The only thing that they commented about was the fact that there was somehow a decrease in fertility for the older women with the youngest group of men. And they think that maybe this is a bias. If you have a donor who is 20 or 19, maybe that person never had the chance to be a father himself. So maybe he is not really fertile. So maybe they have incorporated in that group donor that in fact have never been proven to be fertile men. Conclusion, age of the sperm donor does not significantly alter the live birth rate in females undergoing ART. It's a registry study. There are a lot of potential confounding factors and biases, and that study didn't give any information about the outcome, the health of the children. And you know that this is a growing concern. Another study from the group of Cornell in New York, those cases of very difficult ICSI, the quest for the less than ideal spermatozoid. When you don't have a lot of chance and you have just a few sperms to use, what's the result? In this particular study, what they wanted to address was the fact that sometimes it will take maybe 2 hours to finally get to have 10 sperms. And what they wanted to know is the fact that you are going to increase the time for the quest of those less than ideal spermatozoa, is this quest detrimental? So what they did a retrospective analysis of more than 2,000 cycles. They were related to ejaculated sperm for ICSI and surgically retrieved testicular sperm for ICSI. They classified and they took all the different items, fertilization, pregnancy rate. They did an analysis of motility, and I will present the result. If you take the group of the control in fact are all those cycles for which they could get enough sperms to perform the injection in less than 30 minutes. Those were the easy cases. Well, if you compare those cases to the cases for which you had to do more than 30 minutes, more than 60 minutes, more than 2 hours, or more than 3 hours, there is a progressive decrease in the fertilization rate. So the longer it takes to take the sperm, the lower the fertilization rate is going to be. I think you can disregard this value, the 61% that's clearly above. It's only 2 patients. So it's not something that is really significant on the point of view of the statistics. But interestingly, even if the fertilization rate becomes lower and lower, even if you have a very long duration of search, you still obtain a significant number of pregnancies. Their conclusion was that probably for surgically retrieved sperm, there was a trend towards a lower rate of clinical pregnancy. But for ejaculated sperm, it doesn't seem to make a big difference. What they mentioned about this drop was the fact that, in fact, in terms of counseling, it's a little bit unpredictable. So it's not really reliable to give some statistic to your patient about the chance of obtaining pregnancy. They went a little bit further, and they looked only at the outcome when they had motile sperms. And in that slide, what they present is that if you have, that's the blue bars, motile sperm, you would expect a 75% chance of fertilization. And then you would have some sustained results in terms of clinical pregnancy and delivery. But if you did the same analysis for immotile sperm, the results are not very good. Very low rate of fertilization and lower rate of clinical pregnancy and delivery. And it's the same result for the testicular extracted sperm. So their conclusion is that you have to do this exhaustive quest of the spermatozoids, even in specimens from men with very severely compromised spermatogenesis. And if you have a morphologically and kinetically altered spermatozoid, you can still retain the ability to obtain conceptions. And their conclusion was that probably the fact that you have an egg in front, which may be in fact able to correct and improve the quality of the DNA fragmentation, is also a significant factor. The last communication is a communication from France. The group of Nantes from Paul Barrière, they have been addressing a difficult topic, which is the correlation between BMI in men and fertility. Why is it a difficult topic? I suppose that the literature is very clear about the impact of weight for women, but it's not so clear for men. For women, we know that if they are really underweight and really overweight, the results are going to be lower. But for men, we have very conflicting data. So what they did, in their only center, they did a prospective analysis. All the men presenting for sperm analysis being subfertile, so that's at least 12 months of subfertility, were prospectively assessed. They were given a questionnaire to find some confounding factors, like, for instance, the use of a mobile phone or the smoking or exposure to heat. The only factor that they haven't incorporated in the questionnaire is the use of the boxer shorts. This is something that they couldn't be precise about. And they classified the patients according to their body mass index, being underweight, normal weight, overweight, and obese. They compared the motility of the sperm with visual analysis, subjective, according to the WHO 5th manual, and they also used CASA, computer-assisted sperm analysis. And surprisingly, in their study, there was no difference. Parameters of volume, sperm concentration, total numbers, and motility were not significantly different among all the different groups. The only thing, however, a little bit surprising, was the fact that the group of younger men being underweight, it's not a big number, only 18 people, but those men seemingly had lower motility. And I was walking in the streets of Seoul yesterday. I'm thinking that maybe the problem for you guys is not like us in Sydney, patient being overweight. Maybe all those young guys being very skinny and very young. Maybe you should pay a bit attention about their sperm analysis. So the conclusion of that study is that contrary to what had already been described, there doesn't seem to be any significant difference in terms of conventional sperm parameters and CASA parameters between the obese, overweight, normal weight, and underweight men. So in summary, what have we learned today? The first communication points at the fact that pregnancy remained very good below the 1999 and 2010 WHO norms. Well, this is provided you use controlled ovarian stimulation at the time of the insemination. We've learned that damage to the chromatin is most likely a post-spermatogenetic phenomenon, that it occurs while the sperm is progressing through the reproductive tract. We've learned that the age of the sperm donor does not significantly alter the live birth rate in females undergoing ART. And that the exhaustive quest for sperm in specimens of men having very low numbers and very low motility still can be something rewarding, because you can still find sperms retaining the ability to activate the oocytes, especially in younger women. And finally, that the issue of the correlation between BMI and fertility in men is something that still is open for discussion. 감사합니다. Thank you very much for your attention.